Hi, everyone. So as Erin mentioned, my name is Lauren Hunter, and I'm a doctoral student in epidemiology at UC Berkeley. I'm really excited for the opportunity to speak with you today, but I am getting over a little cold, so please forgive any coughing or extra water breaks. So today I'm going to be discussing contraceptive use and chlamydia positivity among California women seeking family planning services through Family PACT. And I'll be focusing on some implications for multipurpose prevention technology, or MPT development. The analysis that I'll present today arose from a collaboration between Bethany Young-Holt, the Initiative for MPTs, and Heidi Bauer of the California Department of Public Health. And our goal was to use Family PACT data to assess the need for contraceptive methods that prevent STI among young California women. There we go. First, to make sure we're all on the same page, what are multipurpose prevention technologies, or MPTs? MPTs are an innovative class of products that deliver varied combinations of HIV prevention, other STI prevention, and contraception, and have the potential to improve the health of women and families. So certain MPTs may protect against pregnancy and STIs simultaneously, while others may protect against HIV and other STIs while still allowing a woman to become pregnant. We know that women's sexual and reproductive health risks are interlinked. Women who are at risk for unintended pregnancy are simultaneously at risk for HIV and other STIs. And globally, an estimated 40% of all pregnancies are unintended, and more than 200 million partnered women currently have an unmet need for a modern family planning method. There were more than 1 million new infections of curable STIs per day in 2012, and we know that the greatest overlap between unintended pregnancy, HIV, and other STIs is in sub-Saharan Africa. However, even in the United States, STI and unintended pregnancy exacts a very high cost, both personally and economically. About 45% of US pregnancies are unintended, and in 2006, the public cost of unintended pregnancy was estimated at $11.1 billion. And in 2008 alone, the lifetime direct medical cost of newly diagnosed STI cases was $15.6 billion. Condoms are the only MPTs that are currently available, and thus they're the only option, the only available method for simultaneous prevention. But they can't address these issues alone. They're not a realistic option for many women. Currently, less than a quarter of US women who are using contraception report concurrently using condoms. Instead, most contracepting women use single methods that are more effective at preventing pregnancy, but don't confer simultaneous protection against STIs. So we're thinking hormonal contraceptive methods and other high-efficacy methods. Condoms have a higher contraceptive failure rate than many other non-MPT methods, which may lead women to preferentially select methods that don't protect against STI if pregnancy prevention is their primary concern. Also, condoms have to be used correctly during every sexual intercourse to reliably prevent STI transmission and conception, but they suffer from adherence problems. And there are many settings in which women don't have control over condom use due to partner noncompliance. And that all this said, we really don't want to put MPT against condoms. Condoms are safe and effective, they're just underused, and they can be thought of as a very important first-generation MPT. So we need to move forward building on the lessons we've learned from condoms to increase adherence and acceptability. The next step is developing female-controlled and initiated MPTs. Like I said, there are more than 200 million women experiencing unmet needs for a modern family planning method. And these diverse women have very different individual needs and preferences. So our priority should be developing a suite of products that fit women's individual needs, including both on-demand and long-acting options. So this brings me to the motivation for the analysis that I'll be presenting today. As you can imagine, there are many barriers to MPT development, including scientific challenges and the difficulty of developing products that women actually want to use and can easily adhere to. Also, MPT funding has been anchored in HIV prevention and family planning, often in resource-constrained settings. But there's growing recognition that we really need to address unmet needs for the prevention of other STIs that have high prevalence in Western countries, including bacterial STIs like chlamydia and also viral STIs like HSV. There is a current consensus that it's technically feasible, if challenging, to develop MPTs, but their development has been hindered over time by insufficient social and political investment, and insufficient advocacy. So our hope is that producing more research that demonstrates the need for MPTs other than condoms among contracepting U.S. women might be an important step to motivate further investment in MPT development. So this analysis will shed some light on the potential need for MPTs among women who have access to contraception in the U.S., whereas the traditional focus for MPT development has often been in settings like sub-Saharan Africa. So in this analysis, we use chlamydia almost as a proxy for STI risks in general to help build the case for why innovation in prevention method options for women is necessary in our own communities. As a quick refresher, chlamydia is a bacterial STI that is asymptomatic in 80 to 90% of cases, but if it's left untreated, it can contribute to many very serious adverse outcomes, including pelvic inflammatory disease, infertility, ectopic pregnancy, chronic pelvic pain, increased risk of HIV acquisition and transmission, and adverse perinatal outcomes. To give some context to the data that we will see shortly, the estimated global prevalence of chlamydia is 4.2% among women of reproductive age, and there were more than 60 million new infections globally in 2015. And besides being the most common bacterial STI, chlamydia is the most common reportable infectious disease in the U.S., period. And in California, recently in 2016, the chlamydia prevalence among women who are ages 15 to 29 accessing family planning clinics was about 6.7%. Here we can see the incidence rate of chlamydia in the U.S. from 2000 to 2016, stratified by sex. So just keep in mind that this is an underestimate of the true burden of undiagnosed chlamydia, which is likely several times higher. You'll notice that there's a trend of increasing incidence over the years. It's difficult to know to what extent that's an artifact of increased testing and reporting, but in 2016, there were 1.6 million cases reported in the U.S., and more than 1 million of these were among women. This is the highest number of cases of any reportable condition ever reported to CDC, but again, only a fraction of the true burden of chlamydia. In contrast to what we're seeing here, this increase in STI, the unintended pregnancy rate in the U.S. fell to its lowest rate in the past 3 decades in 2011, with declines in unintended pregnancy observed among young and low-income women. The reduction in unintended pregnancy has been attributed to changes in contraceptive use, including increased uptake of highly effective, long-acting, reversible contraceptive methods. So I think what we want to draw from this is that although women are increasingly using contraception, most remain vulnerable to STI. Our study objective was to assess differences in chlamydia positivity by contraceptive methods with and without dispensed condoms, and we'll get into this a little more later, among young female clients of a large publicly funded family planning program in California, PACT. Another way to think about this is, do women who are accessing family planning services using contraception and being dispensed condoms remain vulnerable to chlamydia, and are there differences by contraceptive methods? As we move into methods, I would like to first give full credit conducting the analyses to Lauren Nelson and overseeing them to Joan Chow, both at California Department of Public Health. Lauren had access to billing claims for family PACT clients from the 2012 to 2013 fiscal year, which she linked to Quest Diagnostics chlamydia test results. And this is the data set from which the following analyses were conducted. So I want to note really quickly that the data set only includes women whose tests were processed by Quest Diagnostics, which is about 13% of family PACT testing. Family PACT is a program offering comprehensive family planning services to women in California who fall below 200% of the federal poverty level. And in the 2012 to 2013 fiscal year that the data is from, there were about 2,200 public and private family PACT providers, and they served 1.8 million eligible clients. So although there were more than 1.5 million clients with billing claims in this fiscal year, only 124,000 had a chlamydia test processed by Quest. And for the purposes of this analysis, we focused in on the approximately 75,000 women who are ages 15 to 29. Traditionally, younger women are the target population when we think about STI prevention due to their significantly higher risk. And then once we removed a small portion of the sample who are missing test results or contraception claims, the final sample was 74,636. In the analysis, our exposure with contraceptive methods, in place of the limited traditional codes for contraceptive services, Family PACT has a unique S-code system that's used to identify family planning methods and services covered by the program. Their claims are required to have an S-code in the primary diagnosis field of the claim form, and we use a combination of these S-codes, method dispensing codes, and procedure codes to classify female clients based on their contraceptive method use. In the data set, we classified family planning methods in two ways. So first, we classified clients into one of three contraceptive tiers based on the most effective contraceptive method reported by providers in S-codes or method dispensing codes during the year. So tier 1 included high efficacy permanent or long-acting reversible methods, tubal ligation, Essure, and the implant and IUD. Tier 2, in contrast, was comprised of shorter-acting hormonal methods, oral contraception, the injection, the patch, the vaginal ring. And then tier 3 included lower efficacy coitally dependent methods like barrier methods, emergency contraception, and natural family planning. Second, we created a measure to indicate whether or not clients were dispensed condoms at least once during the year. Clients were included in the condom dispensed category if they had at least one claim with condom in the detail field, or at least one claim with CPT code X1500, which has been historically used in Family PACT to identify dispensing of male or female condoms. And then in sub-analyses, we stratified those contraceptive tiers that I just showed you by the condom dispensing measure as a crude indicator of dual method use. So we classified clients based on tier 1, 2, or 3, and condom dispensing by providers, yes or no. Rather than waiting until the end, I'm going to take a moment here to discuss limitations and issues surrounding method classification in the data, because I think this is an important issue in the analysis. And these are some factors to take into account in order to understand how the classification is done. So first, the data set did not account for method change over the fiscal year. Women were sorted into tiers based on the most effective method with the claim during the year, without regard to the timing of the chlamydia testing. Because both the tiers, contraceptive tiers, and condom dispensing were classified without regard to timing of diagnosis, it's possible that methods changed after diagnosis, or, for example, clinicians distributed condoms after diagnosis. The data also didn't allow for the classification of dual method use, except in the fashion that I just described by combining the tiers with condom dispensing. Again, the condom dispensing measure is not necessarily concurrent with the classification of the tier, so that's something to keep in mind. And then another limitation is that within tier 3, within those lower efficacy coitally dependent methods, barrier methods were billed using the same code as natural family planning. So that made it impossible to isolate barrier methods from other tier 3 methods, which is notable here because barrier methods like the condom are the only methods protective against STIs. It would have been handy. We could have pulled those out. I also want to mention that condom dispensing does not mean condom use or even intent to use condoms. And also that there's potential for misclassification of methods by providers, especially because family PACT clinicians are required to classify a method for billing. Out of the 75,000 women in the sample, only 66 had no method classified. And clearly, I mean, there were more women than that who were not using a method. So some women who don't use a method may have been misclassified as tier 3 users, for example, under the assumption they were using condoms because nothing had been prescribed to them. And then it's also possible that providers underreport condom dispensing, for example, if they're freely distributing condoms in the clinic. Our outcome was chlamydia positivity. Women were classified based on whether or not they had at least one positive chlamydia test. So the number of chlamydia positives does not include reinfection. So chlamydia positivity was specifically defined as the proportion of clients with at least one positive chlamydia test out of all clients tested for chlamydia at least once during the year. We ran log binomial models to estimate prevalence ratios adjusted for age and race ethnicity. Moving on to our findings, we'll briefly look at some demographics. Nearly half of clients, 44%, were ages 20 to 24. You'll see the age on the left-hand side here. And then on the right-hand side, you can see the racial and ethnic makeup. So the majority of clients were Latina, about 58%, with a fifth non-Hispanic white, maybe 9% Asian, 8% Black, and 4% other, including Native Americans. In this chart, we see method classification overall on the left, and then method classification broken down by age group. And here we're just looking at the tier system. So looking at the overall on the left, most clients were classified as tier 2 method users in green. Again, these are the shorter term hormonal methods. While about 19% were tier 1 users, longer acting, more effective methods. And 24% were in tier 3 using the lower efficacy coitally dependent methods. So as you look at the rest of the bars, you'll notice that the use of long-acting tier 1 methods increased with increasing age, that's in blue, while tier 2 classification decreased with increasing age, that's in green. I haven't shown the breakdown by race and ethnicity here, but I want to mention that a majority of clients were classified as tier 2 users across all racial ethnic groups, but Latina clients were the most likely to be classified as tier 1 users. About 24% of Latina clients were in tier 1. And Black and API clients were the most likely to be classified as tier 3 method users. So this does create potential for confounding of the relationship between family planning method and chlamydia positivity, because age and race ethnicity are also both very strongly associated with chlamydia. This graph shows the percentage of women who had condoms dispensed to them, overall in the black on the left, and then by age groups in the gray. So more than a third of clients, 39%, had condoms dispensed to them at least once during the year, and condom dispensing was most common among clients aged 15 to 19, and then it declined with increasing age. And it's not shown here, but Asian clients and Black clients were more likely to receive condoms than clients in other racial and ethnic groups. In this graph, we can see the women in the sample classified into 3 tiers of contraceptive effectiveness, so Tier 1 in blue, Tier 2 in green, and Tier 3 in red. And these tier classifications are further stratified by the condom measure. So the darker columns are the women to whom condoms were dispensed. You'll notice that a greater proportion of the clients classified as Tier 2 method users in green also had condoms dispensed to them. That's the darker green bar, than those classified in the other 2 tiers. Moving on to our outcome, chlamydia positivity. In the sample, 5.1% of the female clients in this age group had at least one positive test during the fiscal year. And let's take a closer look at chlamydia positivity in the sample. The overall positivity of 5.1% is in black on the left, and then it's divvied up by age group. And then in the darker bars of each set of colors is the overall positivity within the age group. And then next to that is the positivity stratified by race and ethnicity within each age group. So consistent with state and national surveillance data, we did find disparities in positivity by age and race ethnicity. So first thing you'll notice is there's a trend of decreasing positivity with each jump in age category. It was about 7.4% among teenagers, women 15 to 19, and then 5.4% among women 20 to 24, and only 2.9% among women 25 to 29. So you'll also notice that there are some pretty staggering disparities by race, particularly among Black teenagers. That's the very high bar in orange, for whom chlamydia positivity was pretty high, 14.9%. When we look at chlamydia positivity by contraceptive tier, we do see slightly higher chlamydia positivity in the second tier, shorter acting hormonal methods, at 5.3%. But as I mentioned earlier, more young women are in tier 2, so it's potentially a younger and higher risk group. Here I've compared the prevalence ratios for chlamydia positivity by contraceptive tier. It's unadjusted on the left and adjusted on the right. In the unadjusted models, you'll notice that women classified as tier 2 users demonstrated slightly higher chlamydia positivity in comparison to the reference group, which was women classified as tier 3 users. However, you'll see on the right that there were no significant differences in chlamydia positivity by contraceptive tier after adjustment for age and race. In the data set, we do see consistently higher chlamydia positivity among women who received condom dispensing, regardless of age group. Overall, on the left, 6.3% of women who received condoms had a positive test, while only 4.3% of women who did not receive condoms had a positive test. Then it's further stratified by age group, and we can see that there's a similar difference in positivity between those who received and did not receive condoms within all 3 age groups. In fact, when we modeled prevalence ratios adjusting for age and race, that's the point in the middle here in this graph, women who received condoms had 1.32 times the positivity of those who did not receive condoms. This graph displays chlamydia positivity among women by the contraceptive tiers, and then stratified by the condom dispensing measure. Again, overall, we see 5.1% of women on the left with positive chlamydia tests in black. And then when we stratified the 3 contraceptive tiers by the dispensing measure, condom dispensing measure, you'll notice that chlamydia positivity is higher among those who received condoms, the darker bars, across all 3 tiers. In this final graph, we see prevalence ratios for each tier stratified by the condom measure, with tier 3 no condoms as the reference group. Again, it's crude on the left and adjusted on the right. The first thing that should jump out is that across tiers, the groups of women who, within each tier who received condoms, had significantly higher chlamydia positivity in comparison to the groups of women within each tier who did not receive condoms. In the adjusted model, the prevalence ratios range from about 1.2 to 1.4 for women who received condoms relative to tier 3 women who did not receive condoms. Otherwise, you won't see any real significant differences between tiers. So let's discuss what was found. We observed high chlamydia positivity in a large and diverse sample of young California women who were utilizing family planning services. And by linking claims to chlamydia test results, our study was uniquely capable of assessing differences in chlamydia positivity by contraceptive methods. And when clients were categorized into those 3 tiers of contraceptive use based on effectiveness, we found high chlamydia positivity across tiers with no significant differences in positivity. But we did observe higher chlamydia positivity among clients to whom condoms were dispensed. And this association persisted when we controlled for age and race and ethnicity, and across contraceptive tiers. There are many ways to interpret this difference because the analysis doesn't take into account the timing of dispensing relative to the timing of diagnosis. We know that correct condom use significantly reduces chlamydial transmission, and condom dispensing that takes place after diagnosis may result from appropriate clinical judgment by providers, or a woman may have a greater motivation to use condoms after a positive chlamydia test. But if prevention does precede diagnosis, the association between condom dispensing and chlamydia positivity may reflect unmeasured differences in STI risk between women who are and are not receiving condoms. Women who perceive themselves to be at a higher risk of STI may be more likely to request condoms. And similarly, providers may dispense condoms to those women who they perceive to be at higher risk based on their demographic traits like age and race, based on their behavioral characteristics like their number of sexual partners, or based on their history of STI or partner concurrency. If we interpret condom dispensing as an indicator of self or provider assessed STI risk, our findings suggest that dispensing condoms that may or may not be regularly used is insufficient for effective STI prevention in this clientele. We can see that people at risk are accurately being identified as at risk by themselves or their providers, and they're being given a method, and this represents a level of success. Providers and women are trying to intervene, they're doing the right thing, they're dispensing or taking condoms, but it's not enough to mitigate all of the risks. Condom dispensing isn't adequately protective against STI, presumably because women aren't consistently using condoms. If we can develop and distribute technologies and put these in the hands of providers that are easier to use consistently and that women want to use, it might better address this risk. To briefly touch upon some limitations, like I mentioned earlier, it's challenging to classify method use and difficult to determine the temporal order of method use in chlamydia testing. So we can't infer a causal relationship between method use and chlamydia positivity, and our analyses didn't account for method change over the year. The data set also does not include behavioral data like number of sexual partners, and this creates potential for confounding of any association between family planning method and STI. So for example, a woman who might choose to use condoms as their primary family planning method because they're participating in higher risk sexual activities, whereas a woman who's using long-acting contraception may be more likely to be in low-risk monogamous sexual partnerships. We also had no information on consistency or correctness of contraceptive use. Also, as I mentioned before, the sample was limited to tests processed by Quest Diagnostics, and this is a small subset of testing done by Family PACT. So this doesn't include a lot of Planned Parenthood clinics, for example. So the sample is less representative of overall Family PACT users in California, but we didn't find substantial differences in contraceptive use or chlamydia positivity by provider type, and controlling for provider type, public versus private, in adjusted models didn't change our findings. Despite our limitations, we can still theorize about the implications of this data set, and more specifically, what it tells us about the need for MPT in this sample of California women. This is a really large data set comprised of a very diverse sample of women who all have access to family planning services and who are, for the most part, using contraception. And still, we see very high prevalence of chlamydia, with significantly higher prevalence in certain subgroups. When you categorize women by these clinician-reported methods, the positivity remains high across the board. Again, this suggests to me that the methods available may not be adequately meeting the sexual health needs of these women who have to weigh the concurrent risks of unintended pregnancy and STIs when selecting a method. And this is where we can see a role for MPTs in helping to address this problem. Getting back to a point I made earlier, women's sexual and reproductive health needs vary depending on where they live and their stage of life and their priorities and preferences. We really need to have a suite of products for women because no single product will ever meet all women's needs. A suite of products and different product types will be necessary if we really want to address the needs of our diverse target population and have the public health impact that we want MPTs to have. There are a variety of different product strategies in the pipeline. MPTs can be co-formulated, for example, vaginal rings that release both drugs simultaneously. They can be co-administered, meaning that there are two products used together, like a diaphragm with a gel, or a contraceptive injectable with an anti-HIV injectable, or they can be co-packaged, which means you have two doses of a drug packaged together in a single product, like Truvada and the pill. In the years since the MPT field has emerged, there are nearly 25 MPT products in development, including vaginal rings that contain antiretrovirals like dapivirine and contraceptives like levonorgestrel. And the combined vaginal ring is actually currently in phase 1 clinical trials. There are also vaginal delivery products like gels and films and tablets. And I want to mention specifically that there are several vaginal gels in development that are protective against chlamydia, including Amphora gel, which is a non-hormonal gel that alters vaginal pH to protect against bacterial STI like chlamydia and also pregnancy. So they currently have a phase 3 clinical trial underway that's evaluating its use for pregnancy prevention, and they're now beginning a phase 2B/3 trial to test specifically its ability to prevent chlamydia and gonorrhea. There are also injectables and implant technologies that are under development. And there's a push for innovation in barrier method design, like, for example, single-size silicone diaphragms that can potentially be used as a delivery method for microbicidal gels. As I mentioned, to reach the potential for MPTs, we need increased scientific innovation, increased funding to support research and product development, and increased advocacy. And the field of MPTs is very complex. The initiative for MPTs, or the IMPT, was launched in 2009, and it has been a leader in facilitating the development of a well-thought-out strategy to advance the field in an efficient, coordinated way. So they facilitate interdisciplinary collaborations, they partner with product developers, social scientists, other researchers, funders, and advocates. They also manage MPT-related knowledge and develop field-wide recommendations. So for more information about MPTs, including what's in the pipeline, research articles, funding opportunities, you name it, you can visit the IMPT website at theimpt.org. And here's just a quick snapshot of some of the products listed in the IMPT's online MPT product development database. All of this is always growing and changing. The product information on each product is laid out in the database along with links to access more product information. And if you're interested to learn more, you can go to the website and sign up for their listserv to receive updates about MPTs as the field builds. And that about wraps up what I have to say. I want to say a really quick thank you to Lauren Nelson, to Dr. Joan Chow, Dr. Bethany Young-Holt, and Dr. Heidi Bauer, who were all instrumental to this project. And thank you, everyone, for your attention.
Okay, I'm not sure if you all heard me. I might have been muted. But essentially, I just wanted to thank Lauren for giving such a great presentation. And now we are going to do a Q&A. So I am going to essentially allow you to just say your name and what organization you're from, and if you have a question, and then you can just say your question, and then Lauren or perhaps Bethany, whoever is appropriate to answer the question, will answer. And I think what I'll do is I'll just leave everyone unmuted, and I'll just ask, like, if you don't have a question or if you have a lot of background noise, to simply mute yourself and then come off of mute if you have a question. So if you have a question, just feel free to go ahead and ask it, and I'll leave everyone unmuted so that Lauren also can respond.
Hello, my name is James. Yeah, my name is James. I'm working with the World Health Organization. And thanks, Lauren, for a very good presentation. I think it's very informative, particularly to see the very high prevalence of chlamydia even in this population. My question is regarding the issue of access to treatment and testing. Suppose these women had not been coming to the family planning program, what would have been the access to diagnosis and treatment been like? And how much benefit do you think they derive from just coming for contraception services by this additional benefit they get of accessing chlamydia diagnosis and treatment? Thank you.
Hi there. So let me try to make sure I understand your question correctly. So you're wondering about, you mentioned women who are not accessing these services versus the women who have the benefit of access. Would you mind clarifying?
Yes, so my question is, you are providing this service, but not all women are coming for contraceptive services in the US. So for other women who are not coming for contraception, what is the access to chlamydia testing, diagnosis, and treatment like? Or is this a service that is kind of available when they come for contraceptive services and otherwise not available if they are not coming for these services?
Okay, so I think I understand better. So I would say this question might be better answered by some of the experts in STD control at CDPH in terms of what is available for women who aren't accessing contraceptive services. I would say for many women, they're not able to access chlamydia testing unless they do have a care provider of some sort who can help them. So whether that is Planned Parenthood or family PACT providers or their own private provider under their insurance. So I don't know if perhaps Lauren, Joan, or Heidi might have something else to contribute, talking about women who are not coming for contraceptive services and what might be available to them in terms of chlamydia testing.
Hi, this is Joan Chow here at the STD Control Branch, and I think getting access to chlamydia screening for young sexually active women is probably one of our biggest challenges. Even though we have these great tests that are very sensitive and specific, I think you're right that women who are already accessing care in family planning probably have the best, they're positioned best to receive these services. But what about women who are not being seen in family planning services, women who are being seen in primary care, managed care, community health centers, and so forth? And there are a lot of those women who are accessing care, and we hope that primary care providers in these settings are able to conduct a comprehensive risk assessment to identify those women who are eligible to receive chlamydia screening. And this is probably one of our major priorities, I think, as an STD program, is to work in collaboration with those providers, especially as more women over the last couple of years have been able to have access to health insurance that enables them to seek services in these community settings. And so from measurements of chlamydia screening in managed care, we know that there is a big gap in terms of access to chlamydia screening in these non-primary, non-family planning settings. Managed care is probably only really screening about 50% of young sexually active women who seek care in those settings. And so we know we have a major gap to overcome in order to be able to identify and treat these primarily asymptomatic infections among women who are accessing care. Then, of course, there's a segment of young sexually active women who aren't even accessing care at all in any of these settings, and I think that there's some exciting possibilities in terms of online chlamydia screening programs that have been conducted in a number of different cities, where it's possible to actually get screening tests sent to your home, and thereby allowing you to have access to screening, which is important for people who, for a variety of reasons, don't want to seek care, to go into a clinic and actually see a provider, but at the same time have access to these online testing services that allow them to be screened in a confidential manner and hopefully get connected with treatment if they are found to be positive. And so there are a number of very, very promising non-clinical screening services that enable those women to be served. But again, uptake can only be improved, with these methods. So does that help you get a better sense of the options that are available for young sexually active women at risk for chlamydia, at least in the United States?
Yes, thank you.
Thank you.
Thank you, Joan. That was really insightful.
Hi, this is Dave Friend. Just wanted to also thank Lauren for a very interesting webinar. And like you, I think we've at Evofem here we've shared and understood the focus on HIV prevention, but we are quite pleased, and thank you for mentioning the work that we're doing to develop a contraceptive gel that should also prevent transmission of, initially we're focusing on chlamydia with secondary indication or endpoint of gonorrhea. So yeah, so we are kind of almost single-handedly, I think, trying to put more funding into non-HIV prevention work. And so we're quite excited about that, and I'm glad this webinar came up quite timely, since we just announced that we were starting the prevention study for chlamydia. So it's more of a comment than a question.
Well, thank you very much for listening today, and I'm looking forward to hearing more about Amphora as the trials progress.
Yes, thank you.
This is Bethany, and Lauren, thank you, for such a great presentation. I wanted to circle back to a conversation I had with James Chiari from WHO about a week ago and maybe James, you can elaborate a little bit more on the concerns you're feeling about a potential correlation between chlamydia and infertility, and how that might also be something that's, we have a lot of infertility issues in the U.S. as well. So I think on a global scale, globally and, what's going on here in California, not too different. So I didn't know if you wanted to speak a little bit to that.
Yes, thank you, Bethany. I think the data that Lauren presented was quite interesting for me. Particularly to see the very high prevalence among Black women, which is almost the kind of prevalence we are seeing in some of the countries globally. For me, I am coming at it also from the perception that one of the biggest barriers to contraception, particularly among adolescents, is these concerns regarding infertility, that adolescents feel that if they use contraception and delay pregnancy, they may be unable to conceive later. And I think these MPTs to prevent STIs and provide contraception, or the treatment programs in contraception services, really present an opportunity for us to address this concern. And therefore and hence my question about what access people have to chlamydia testing outside the contraceptive services, that beyond just being able to delay pregnancy until the adolescents are older and until they are ready for pregnancy, these services may actually be providing some role in terms of assuring fertility, and maybe this is an issue that has not been addressed as a benefit to contraceptive services, that then you can be able to get diagnosis, treatment, and prevention of STIs, which therefore protects one against infertility and all the costs and issues that are associated with that. So we are very interested, I think, for us at WHO, looking at particularly in lower and middle income countries, as to what lessons we can be able to learn and move into those settings that can strengthen the issues of prevention of STIs and early diagnosis and treatment of STIs in those settings. Maybe to take this opportunity to also ask a follow-up question. in terms of Laura, I think, presented overall prevalence, and some of the clients were being tested more than once. For the clients who had repeat testing or follow-up testing, having been treated, how much of the recurrent? I don't know how are you if people tested positive twice or tested positive and then negative. How are you treating that data in this analysis? And is there a sense that once the client's test may be chlamydia positive and you provide treatment and condoms maybe, you have a reduced risk of recurrence? I don't know whether the question is clear.
I think it is. So your question about what if someone tested positive twice or positive once and then negative once, the way we defined chlamydia positivity, a woman was considered yes, if she had at least one positive. So whether or not she was tested multiple times, if at least one of those tests was positive, then she was classified as yes. So that was the 5.1% that we saw. And then women who were tested once or more than once who never were positive during that year, those were classified as chlamydia negative. So your question there. And then you said, ask if there's a sense that if they test positive and provide condoms, if that would reduce chlamydia positivity. I think that's a great question, and I wish that is something that we could look at with this data, because I know, a lot of the condom dispensing happens the day that they were tested, or maybe before or after. Unfortunately, we just don't have the temporal ordering of events in a way that would allow us to look at a positive test followed by condoms versus a positive test not followed by condoms. But if we did, I think that would be a great thing to do.
Yeah. Okay. Thank you.
Thank you.
Just a quick reminder, if you have a question, go ahead and if you're muted, unmute yourself, and if not, just go ahead and say your name, organization, and what your question is. And they'll give everyone another minute or so to ask the question, and then if there are no more questions, we will go ahead and wrap things up.
Hi, this is Chrissy Leahy, and I work at Essential Access Health. And one of my questions was, I was curious if there was any analysis around some of the racial disparities and why they were so high, if there was any information collected there. And then also, second question in regards to MPTs, is there any consumer data that's also being recorded to see if the interest among different women and what that does look like, especially with groups that might have a negative experience with reproductive health services or just healthcare in general?
So for our present analysis, we didn't do any more analyses looking at why those racial disparities exist, but I know there are a number of papers that explore racial disparities in STI, and I actually think that I'll pass this over to two people. First, I'm going to pass it over to someone who is at CDPH STD Control Branch, because I'm sure they have the most up-to-date information. And then your second part of your question about consumer data being recorded about interest in MPTs, I do believe that there have been some recent studies even looking at preferred contraceptive method features, and I believe there was a recent paper, and I'll have Bethany speak to this, that was looking at women's interest in MPTs. That's certainly a very important sphere of research that is ongoing to try to figure out who would be the market for this. And like you mentioned, especially among groups that maybe were historically marginalized or might have some suspicion of what providers are giving to them and why. So perhaps if someone at CDPH might want to talk about racial disparities, and then Bethany can follow up about consumer data.
Hi, this is Dr. Heidi Bauer. I'm the chief of the STD control program for the state of California, and I think it's a complicated issue. I think there are multiple different explanations and multiple different factors going on simultaneously. And even in California, where we are relatively resource rich and we have good access to services, there are still some pretty significant barriers that tend to fall along socioeconomic and race lines. And so if folks are not getting the services they need, and particularly since chlamydia is primarily asymptomatic, screening is the main service that, makes the biggest difference in terms of population positivity or prevalence. And so if folks are not able to access those services because of financial barriers or other kinds of barriers to accessing traditional health care, they may be more likely to have their infections longer and then spread those infections to other partners. There are data in, not so much probably state data, but national data looking at differences in risk behavior, and there are certainly differences that are observed among some of the younger populations and earlier age of sexual debut, on average greater numbers of sexual partners and partner change. And so we do see some differences in the kinds of risk behaviors that put people at risk for STDs and for chlamydia. But I think in general, we think it's a combination of those things, and related to sort of accessing services is differences in access to information and education. And there are still significant disparities in how much information people have about their own health, their own sexual health, how much information they're getting in schools, and how much encouragement they're getting to seek services when they need services. I'm not as familiar with sort of teen pregnancy data and disparities in teen pregnancy data. I know that we have high rates in Latinas in California, and I think there are probably some cultural factors driving that. I don't know whether the rates of teen pregnancy are higher in African American youth, and so that would be an interesting thing to look at if they're accessing contraception but not really availing themselves of other kinds of sexual health services. There might be some disparities that arise there. So I'm sure there are other explanations, but I think those are the things that come to my mind immediately in looking at these data. And all these women in the study had access to family PACT and contraceptive services, and so that's to some extent controlled for, but I think there are still barriers out there.
I want to follow up on Heidi's great comment just by mentioning that among adolescents, there certainly are still disparities among Black adolescents in terms of the teen birth rate. I think it's about twice as high compared to non-Hispanic white, and fairly similar to Hispanic or Latina adolescents.
Oh, thanks, Lauren. That's in California?
This is nationally.
Okay, thank you. Yeah, California may be a little different if nationally includes the South. And the southern states in the United States have pretty profound challenges in terms of clinical services and resources and social support.
Great. So this is Bethany, and Are you done, Heidi? Otherwise, I'll take a stab at the next question.
Yeah, go ahead. Thank you.
Okay. So the question around consumer data and end user research around MPTs is really important. And I'll just say that at the very onset of the launching of the MPT field, it was really a big priority to really include end user preferences around MPTs. In other words, really understanding what women and adolescents want in a product throughout the product development process, so that once an MPT or a range of these products are developed, they're actually going to meet the needs and desires of women and girls, so they'll actually be used. I wanted to say that is a big priority, but unfortunately, there's not a lot of it's a gap in terms of funding. So that is something that the initiative is really working to highlight, that there needs to be more research that goes into really understanding end users and what women and girls want around the world. But that said, there have been quite a few studies recently coming out on end user preferences and the potential market for MPTs, particularly in sub-Saharan Africa. The MPT field, as several people have said, David Friend highlighted this too, has really focused a lot on HIV and contraceptive MPTs, and the HIV burden is just tremendously high in adolescents and young women in sub-Saharan Africa. So a lot of work has been going into that from USAID and the NIH, but there's clearly a huge need for these MPTs elsewhere as well. And so there unfortunately hasn't been a lot of that kind of research in the U.S. There have been a few studies and in other places. So that is an area where more research is really needed. Hope that answers your question. If you are interested in looking at those studies, the IMPT website has a resource center where those kind of studies are housed too, and sort of collectively. So that's thank you.
We'll give everyone about another minute if there's any more questions. Now is the time to ask. All right. Well, if there are no more questions, I think we'll go ahead and start to wrap things up. First of all, I just wanted to thank everyone today for attending and also for asking such insightful questions, because I think it really added to the depth of the presentation. And Melissa, I want to turn it over to you to talk a little bit about ASHWG, since this is our first webinar that we're hosting as an organizational body.
Yes, so this webinar has been brought to you by ASHWG, which is the Adolescent Sexual Health Working Group. We're an organized collaborative of governmental and non-governmental organizations, and we promote and protect the sexual and reproductive health of youth in California. And ASHWG is comprised of program managers and coordinators from different governmental departments such as the Department of Public Health, Department of Education, and other key non-governmental organizations. And we meet 3 times a year. And if you want to find out more information about ASHWG, I would recommend you visit our website, ashwg.org, and we also are on Facebook. So I thought this would be a good time to let people know. We're also recording this webinar, and the recording of the webinar will be posted to the ASHWG website. With that being said, I want to thank everyone that participated today, and yes, thank you.